Today we are honoured and delighted to be joined by Dr. Pavan Minhas, who is a graduate from KCL and Obs and Gynae registrar. I know for one that I really struggle with gynae, so I'm quite looking forward to this lecture personally. But of note, Dr. Pavan also runs a blog on women's health and has her Instagram tag there. If you guys did want to go follow her, please do. But without further ado, I will let you get on with things, Pavan.
Oh, perfect. Okay, thank you for that lovely introduction. So yes, I'm an ST4 in obstetrics and gynecology, and today I'm going to go through gynecological emergencies, specifically looking at bleeding in early pregnancy. We'll do some cases as we're going along, and also do some MCQs, so we can get started now. So there's lots of causes of bleeding in early pregnancy, and it's really important to think of things other than the obvious. So most people, if you say bleeding in pregnancy, they'll think of miscarriage, they'll think of ectopic pregnancy, but there's lots of other potential causes as well, such as subchorionic hematoma here, and that's basically having a collection of blood underneath the placenta. You can have an implantation bleed, which women often get, you know, in their first month of pregnancy. So they don't know that, some women don't know that they're pregnant because they had their period that month. You can have polyps, which are overgrowths of tissue, which could be the uterine tissue. There can be cervical polyps, vaginal polyps, and these are usually benign and non-malignant. You can have cancers, cervical cancer, vaginal cancers, so you should always think about that as well. And this is exactly why doing a speculum examination is important. We also have pelvic inflammatory disease, so thinking about chlamydia, gonorrhea, women can still get that in pregnancy. And then there's obviously trauma, and also fibroids, which are smooth muscle growth, usually in the uterus, but again, you can have them in the cervix as well. And also here we have cervical ectropion. So a cervical ectropion is a reddened area that you might examination, and it's basically the cells from the endocervix, so the cervical canal. It's lined with glandular cells, and as these grow down, they come onto the surface of the cervix, and they appear to be red in colour often, and that's a normal finding. But women can get postcoital bleeding, so bleeding after intercourse, with a cervical ectropion, but it's a diagnosis of exclusion. So moving on, we've got this case here that I just want you all to take a read of. So a 36-year-old, gravida 3, para 1+1. So gravidity is talking about what number pregnancy this current pregnancy is. So this is her third pregnancy. Parity is number of deliveries that she's had or pregnancy losses. So she's a para 1+1. So she's had one delivery, which was after 24 weeks, so that's the para 1, and that is what is considered as a viable pregnancy. And the +1 can refer to anything from miscarriage to ectopic pregnancy. So that's what information we've got here. She's a para 1+1, and she presents with vaginal bleeding. Her last menstrual period was 7 weeks ago, and she's had a positive urine pregnancy test 2 weeks ago, so she's about 7 weeks pregnant. And for the past 2 days, she's had generalized abdominal pain, which is now localized to the lower abdomen and pelvic area. And the bleeding has also been there for 2 weeks now. She's feeling a bit dizzy, a bit lightheaded. On examination, she looks a bit pale. She's in some discomfort, but the abdomen's soft with just some lower abdominal tenderness. So you go on to do a speculum examination, and you're able to visualize the cervix, but she's not actively bleeding. You do some observations, and you find that she's slightly tachycardic with a heart rate of 110. Her blood pressure is 96/62, so a little bit low, but could also be normal for her. and respiratory rate is 15 and stats are 98% in room air. Her temperature is 37.2, so she's afebrile. So I want you guys to have a think of this case, look at the information that you're given here, and try to pick up any clues to see what could be going on with this lady. I'm just going to give you a minute just to have a little look at that. You might want to write down the most important points and the most important clues if you think there are any within that text. So question 1 now is, what is the most likely diagnosis? So A, ectopic pregnancy, B, complete miscarriage, C, incomplete miscarriage, D, threatened miscarriage, and E, I'm not sure. Don't worry too much if you don't know exactly what these different types of miscarriage are. We will speak about that, but just try and have a go and see if you can try and think of what you think might be going on here, or if you're not sure, that's absolutely fine as well.
Just for those of you, we don't actually have a poll for this lecture because of the technical difficulty. So please just pop your answers in the chat and I will let Pavan know which are the most popular answers. So we have a lot of Ds,
Okay.
lots of As and Ds I can see. Not very many, a couple of Es here and there, a couple of Bs. It looks like A and D are the most common answer.
Okay, fine. So if my SHO came to me and said, gave me this history and these examination findings, to be honest, my answer would be E. I'm not sure, because I don't think that there's enough information within this case presentation to be confident in saying that it's a threatened miscarriage or a complete miscarriage or an ectopic pregnancy. There's just not enough in there. This history is very vague. There's no specifics in there. That para 1 + 1, what was that +1? Was that a previous ectopic pregnancy? Was it a previous miscarriage? Even her pain, it's localized to the lower abdomen, pelvis. So that's a large area that they're sort of describing that pain being, and there's nothing specific there. And she said vaginal bleeding for 2 weeks, but there's no further information on what the blood loss has been like over those 2 weeks. So for me, the answer to this would be E. I'm not sure. And does that make sense to you?
So everyone is agreeing that it definitely makes sense. So, well, that's a good explanation.
Good. So when you're taking a gynae history, obstetric and gynae history, there's certain things that you need to ask, and there's certain things that you need to know. It needs to be a detailed history so that you can pull out all the relevant information from the patient. You're a detective, you're trying to tease out as much as you possibly can to get a really detailed history, and it's so important. So start with the basics, ask the patient how old they are. And then when you're asking about the bleeding, you want to know more about it. So when did it start? What was the bleeding like when it started? If they say it was light spotting, is it still light spotting or has it changed at all? How many pads are you changing per day? They might say to you, I'm changing 6 pads a day. I always ask, is that because of hygiene reasons or is that because your pads are soaked? It's also important to ask about the type of sanitary pads they're wearing. Are they wearing panty liners, which will obviously get soaked very quickly? Or are they wearing thick pads, which, that's worrying. If a woman's wearing thick pads and changing them every hour, then you'd be a bit more worried about a woman who's changing a panty liner every couple of hours, mainly for hygiene reasons. You'll also ask about whether she's passing any clots, and then ask about the size of the clots. And I usually ask about clots in terms of coin size. So are they like 5p size? Are they 50p size? Are they stringy clots? And also ask about flooding. So are they leaking through sanitary pads into their underwear or into their trousers? So try and get as much information as you possibly can from the patient. Next, we'll move on to pain. So ask about pain. Are they experiencing any pain, and what is the pain like? So to this day, I still use Socrates because I think it's the best way of getting the most information about the nature of pain that the woman's experiencing. So where exactly is the pain? And I'll actually ask the patient to point to the pain. She'll say, oh, it's in the lower tummy. And I'll say, can you just point exactly where that pain is? So that site, and then onset of the pain. Did it come on all of a sudden? Has it been a gradual onset? And what does it feel like in character? Is it a sharp stabbing pain? Is it a crampy pain? Is it a period-like pain? And does it radiate anywhere, for example, into the thighs or into the back? You know, that sounds more like period-like pains, or cramping pains, like which radiates into the upper thighs or back. Ask about associated symptoms. So have you had any vaginal discharge? And if they have, then ask about colour, smell, if there's been a change in discharge. It's also important to ask about urinary symptoms, as we would in most of our history taking. What else would we ask about? Fevers, rigors, thinking about infection. Ask about when the pain started, how long the pain's been there for, and then exacerbating and relieving factors. Is it worse on movement? Is it better on lying still? Is it relieved by taking paracetamol? Have they even had to take any paracetamol? Is it not bad enough to need any analgesia? And then also ask about severity of the pain. So ask them to grade it out of 10, with 1 being the least pain and 10 being the worst pain they've ever experienced. So all these things are going to give you lots of information about that pain. Also ask about whether they've seen any tissue that's been passed, so any white sort of fetal tissue or anything unusual other than blood and clots. It's also important to take the menstrual history, and I usually ask this near the start of the history, actually, just to ask them when their last menstrual period was. Ask them whether their cycles are irregular or whether they're regular cycles, and how many days from the start of one period to the start of the next period. And then go on to ask them about any scans they've had in this pregnancy, because then you'll know, they might tell you that actually I had a private scan 2 weeks ago or a week ago, and the pregnancy was seen in the womb and there was a fetal heart present. So to ask about scans. And then you want to know more about their obstetric history, so gravidity, parity, pregnancy losses. So the way that I tend to ask this question, because if you ask a patient how many children do you have, she might just say, oh, I have 2 children. She might have had a stillborn baby. She may have had some miscarriages or ectopic pregnancies. So the way of getting around that is asking, what number pregnancy is this? And so she might say it's pregnancy number 4, and then I'll ask, how many children do you have? And she might say, I have 2 children. And then I'll sort of ask what happened with the other pregnancy, and then they'll tell you whether it was a miscarriage or ectopic or a stillbirth, because some women will say that that's one of my children, whereas some women might not give you that information about a stillborn baby as being one of their children. Now they might not count it, so it's important to ask in a sensitive manner, and all of this history taking has to be in a sensitive manner, because bleeding and pregnancy is really worrying for women, and what you say to them will stay with them for a very, very long time. Also ask about mode of delivery. Have they previously had cesarean sections or normal deliveries? Ask about gynae history, so in terms of pelvic inflammatory disease, previous ectopic pregnancies. Smear history, are they up to date with their smears? Have they had any abnormal smears or any treatment to the cervix, such as large loop excision of the transformation zone? That's the Letts procedure, which you remove the cells of the cervix if there's any high-grade abnormalities. In the contraceptive history, ask them whether they're using any contraception. They may tell you that actually I've got a coil in, so I wasn't expecting to be pregnant, and I don't know how it's happened, but I do have a coil in at the moment. So it is rare. A coil is a very good form of contraception, but there is still a small risk of pregnancy. And if you do become pregnant, then your risk of having an ectopic pregnancy is higher in that small proportion of women who do fall pregnant with the coil in place. Progesterone only pill also can increase your risk of having an ectopic pregnancy if you do fall pregnant. So it is 99 or over 99% effective if you're using the pill as it should be used. But of those who do become pregnant despite taking the pill, 1 in 10 of those will have an ectopic pregnancy. So keep that at the back of your mind. Ask about medical history, surgical history, as you would do normally, drug history, any regular medications they're taking, any allergies to medications, and also ask about smoking and alcohol. So moving on to examination. So you do your general inspection. How does the patient appear? Do they look well? Do they look alert or drowsy? Do they look pale? And what's around them? Have they got, inco pads which are soaked with blood, or is there, are their jeans completely soaked in blood? Are there any soaked pads nearby? And if there are any pads nearby that are soaked, it's worth having a look, because you'll be able to see how heavily soaked they are, what sort of pads they are, and whether there's anything more than blood and clots there, if there is any tissue there as well. Then move on to the hands. Are they warm, well perfused? What's the capillary refill time? You're looking for signs of shock. If they've bled heavily, is there signs of hemorrhagic shock essentially? Is there feel for their pulse, the volume? Is it a regular pulse? And then move on to abdominal examination. So again, inspecting the abdomen and then moving on to palpation. And you don't usually percuss or auscultate in your gynae abdominal examination, but if there were any other signs that you were worried about, then you can always do that as well. So palpate around. Is there any tenderness, superficial tenderness or deep tenderness? Any signs of peritonism? Are they guarding? Is there any rebound? And then move on to speculum examination. So this is a sensitive examination. Don't just assume that the patient knows what a speculum is. She may never have heard of a speculum before. She may never have had a smear test before. So please don't assume. And there's a picture there on the right hand side of a speculum, and just let them know what it is. So I need to do a speculum examination, and that involves putting a plastic tube called a speculum into the vagina and stretching the vaginal wall open so that I can see the cervix, which is the neck of the womb. And this is quite important because it will give me lots of information about how much you're bleeding and whether there's any tissue or pregnancy tissue that's being passed. And it will help me to establish what I need to do next. So that's how you explain to the patient about what a speculum is and why you need to do it. And you should always do a speculum examination and any intimate examination with a chaperone present. So the GMC says that you should offer a chaperone to the patient. They can decline, but I would really urge you, in these intimate examinations, these gynae examinations, they should be done with a chaperone present, especially at your levels. If you're ever left alone as a medical student and just told to get on with the speculum, I definitely wouldn't do it without a chaperone present. And also take relevant swabs. So a high vaginal swab will look for infection, and then you may want to take endocervical swabs as well if you're thinking about pelvic inflammatory disease. But that will depend on what you get from the history. And then obviously a bimanual examination as well, but gently, because if there is an ectopic pregnancy there. You don't want to disturb it, you don't want to cause it to rupture, so it should be a gentle examination. So cervical excitation is basically when you put your fingers into the vagina, and when you touch the cervix, if the patient jumps up in pain, then there may be a big ectopic pregnancy, so it's a sign of peritonism, something going on. It could be a tubo-ovarian abscess even. And also feel for any pelvic masses. So please let me know if I'm going too fast as well. So next up, you move to investigation. So look at the patient, and after you've examined them, make sure you get some observations done, specifically looking at heart rate, blood pressure, respiratory rate, oxygen saturations. Are they on oxygen or are they in room air? And their temperature as well. So you want to think of, are there any signs of infection, any signs of shock, and hypovolemic shock in particular. And then bloods, you'd want to do a full blood count, you'd want to do a group and save, you'd probably do an arterial blood gas if the patient looked unwell, and you may consider doing a beta HCG, but we'll talk more about that shortly. In terms of imaging, we would recommend a transvaginal ultrasound scan rather than a transabdominal ultrasound scan, because you get a much more detailed scan. You can pick up much earlier gestation pregnancies doing a transvaginal scan as well. And if you see a pregnancy in the womb, an intrauterine pregnancy, then you may be able to see a gestation sac. Hopefully you can see a yolk sac. You may see a fetal pole, and you may see cardiac activity as well. If it's an ectopic pregnancy, then the scan report may describe an adnexal mass. There may or may not be a fetal pole present. There may or may not be fetal heart activity present, and there may or may not be free fluid in the pouch of Douglas. And when there's a pregnancy of unknown location, then the scan report will usually say that there's no pregnancy seen, intrauterine or extrauterine, or they may just comment as the adnexa look normal, and no signs of ectopic pregnancy. So in this situation, you don't know where that pregnancy is, and you need to investigate further with serial HCGs, and we'll speak about that in a minute. So this is the next case. So you have a 36-year-old primiparous lady, so she's a para 1. She presents with heavy vaginal bleeding. Her last menstrual period was 7 weeks ago, and she had a positive pregnancy test 2 weeks ago. She woke up with lower abdominal cramping and a pool of blood in her bed. She has been continuously bleeding for the past 2 hours and is flooding through pads. She feels dizzy and lightheaded. So that's a good history, and there's lots of important information that's being picked up from the history there. On examination, she looks pale, and she's wearing trousers which are soaked in blood. The abdomen is soft with mild suprapubic tenderness. Her speculum, she is actively bleeding, and it's difficult to visualize the cervix. Her heart rate is 110, her blood pressure is 96/62. Her resps and oxygen saturations are normal, and she's afebrile. So the options on the right for the most likely diagnosis are complete miscarriage, missed miscarriage, threatened miscarriage, complete miscarriage, or hydatidform mole. So what do you guys think the most likely diagnosis is in this case?
If you guys comment your answers in the chat, I'm just going through them now. We have a lot of D's. Someone said F, so that's not an answer.
Is that D?
Yeah, a lot of people are saying D. That seems to be the consensus. Okay. Got a couple of A's, but yeah, it looks like people are set on D.
Okay, So exactly. So I would agree. The answer to this one is D, and the reason that it's D is because she's she's bleeding really heavily. She's actively bleeding. You've done a speculum, and although it's difficult to visualize the cervix, there's ongoing bleeding and it's heavy. So you wouldn't find that in complete miscarriage. In missed miscarriage, they often don't get any bleeding at all, and it's just picked up on their 12-week scan. Threatened miscarriage is just light bleeding, and it's not really fitting in with this diagnosis. Although I agree there aren't any scan findings that I've presented here, so that doesn't completely rule out a threatened miscarriage. But I think given this history, it's less likely to be that. So a bit more information here. So you remove clots from the vagina and are now able to visualize the cervix. The external cervical os is open, but the bleeding is ongoing. She's very pale and her blood pressure is now 60/40 and her heart rate is 117. She's resuscitated with IV fluids and O negative blood is on its way. Bloods were taken 20 minutes ago, and that was for full blood count, group and save. The full bloods were taken. And at this point, you're estimating that her cumulative estimated blood loss is 1 litre. So what is the best management option for this patient? So is it expectant management, which means just let her carry on and it should just resolve on its own? Medical management with misoprostol, surgical management, doing evacuation of retained products of conception, medical management with mifepristone, or medical management with methotrexate. So have a little think and let me know what your answer is to this one.
I think about 98% of people, probably just looking at the chat, have said C, with a few D's here and there, but we've mainly got C. So that's surgical management.
Okay. So good, yeah. I'm worried about this patient. She's unstable. She's her observations are clearly telling you that she's in hypovolemic shock there. You're that worried that she's been resuscitated with IV fluids, and you're going to transfuse her as well. O negative blood is on its way. So you wouldn't let this patient continue as she is. So it's definitely not A, expectant management. Medical management isn't appropriate in this case either, because she's actively bleeding. She needs resolution of this episode as soon as possible so that she can, be stabilized, and so you can stop that bleeding. And the only way that's going to happen is with definitive management using evacuation of retained products of conception. So the answer for this is C. So now we'll just move on to talk about miscarriage. So it's pregnancy loss before 24 weeks gestation. That's what we use as a definition in the UK. The WHO definition also says expulsion of fetus or embryo weighing less than or equal to 500 grams, and has a gestational limit of less than 22 completed weeks of pregnancy. So it's slightly different to what we use here in the UK. In terms of epidemiology, it affects 1 in 5 pregnancies, so it is extremely common. It's something we're seeing very, very often in our early pregnancy clinics. And the majority of these occur before 12 weeks gestation. And that's what 12 out of 40 means, because 40 is a term pregnancy. So 12 out of 40 is 12 weeks gestation. Less than 4% of miscarriages occur in the second trimester, so that's after 12 weeks, and less than 5% of miscarriages occur after fetal heart activity is identified. So if they have a scan and a fetal heart is seen, then their risk of miscarriage does really drop down. Early pregnancy loss accounts for 50,000 UK admissions annually, and it has a significant psychological impact on patients and their families and partners. So at this point, I think it's really, as mentioned earlier, really important just to highlight again that how you treat this patient and how you interact with this patient is going to stay with them for a very, very long time. You know, women are often really affected by pregnancy loss in itself, but then if they have a really horrible experience when they're in hospital, then that makes it even worse, and it can impact future pregnancies as well. So be very, very sensitive when you're talking to these patients, and take the time to listen to them and find out what they're worried about and what their concerns are as well. So the main cause in most miscarriages is chromosomal abnormalities, but there are other causes, including infection, and I've just listed some of the common ones there. Advanced maternal age is also a risk factor, and this table on the side here shows that your risk of miscarriage when you're less than 20 years is 15.8%, so it's slightly higher than the 25 to 29 age bracket, which the risk of miscarriage is 10%, and the lowest risk is actually when you're 27. I think the risk is about 9.5% at that point. And when you're over 45 or 45 or over, your risk of miscarriage increases to 53%. So that's, you know, really very significant. Other risk factors include multiple pregnancy, assisted conception, so IVF pregnancies, fibroids, and uncontrolled diabetes is also a risk factor. So hopefully this table can help you to identify the different types of miscarriage and what you might see. So would you like me to speak through it, or do you want to just take a read yourself?
So I think people are saying they want you to go through it and just compare the different ones.
Okay, that's fine. I thought they might be sick of my voice, but that's fine. We'll carry on. Okay, so threatened miscarriage. So they usually present with bleeding. They may or may not have abdominal pain. The bleeding can vary from light spotting to a period-like bleed. But when you examine them and do a speculum examination, the cervical os is usually closed. And when they have a scan, you see an intrauterine pregnancy and often see a fetal heart present. So this is a viable pregnancy. A complete miscarriage, they usually say that their bleeding is settling, but they'll probably describe heavy bleeding prior to that. They may say that they were passing large clots. They may say they think that they've passed their pregnancy sac, but the bleeding is now settling. And when asked about pain, they also say that, you know, the pain's also settling now. And when you do a speculum examination, the cervical os is closed. So the products are passed in this case already, and the uterus is no longer enlarged. So when you do a bimanual examination, it's not a bulky enlarged uterus, it feels small. Next, we have incomplete miscarriage. So they will often have bleeding, ongoing bleeding, and it can be heavy bleeding that they're having as well, like we described in the case earlier. They're also having ongoing abdominal pain. They'll often explain that it's period-like cramps that are coming and going, or a constant pain which is intermittently worse. And when you do a speculum examination, the cervical os is open, and this is a non-viable pregnancy. Inevitable miscarriage, they may say that they're having heavy bleeding and they're having abdominal pain, and when you examine them, the cervical os is open. If they have an ultrasound scan, then the fetal heart may be present, but the miscarriage is about to occur because that os is open and that pregnancy will be expelled from the uterus. With a missed miscarriage, as I mentioned earlier, they may not have any symptoms at all. They may just turn up for their 12-week scan, which is their dating scan, and it may be diagnosed at that scan that that there's no fetal heart seen. or they may have some light spotting, and again, they have a scan and there's no fetal heart seen, and the cervical os is closed. But this is not an ongoing pregnancy. This is not a viable pregnancy. So in terms of management, let's split it up into conservative, medical and surgical management. So conservative or expectant management is successful in around 50% of cases. As long as the woman is willing, it's an acceptable form of management, and it is actually recommended as first line for the first 7 to 14 days, as per NICE guidance. But obviously it depends on what you're seeing in front of you. If you've got the woman that we had earlier who is hemodynamically unstable with ongoing active bleeding and who has lost significant amounts of blood already, you're not going to leave her be for 7 to 14 days because she won't survive. So you need to make sure that there's no signs of infection. So make sure you do ask about vaginal discharge, and there is a 3% risk of infection with conservative management. So explain what the signs of infection are and advise them to contact the early pregnancy unit or seek medical advice if they do experience any of these symptoms. So vaginal discharge, which is unusual or different to normal, excessive bleeding, pyrexia, or if they're having abdominal pain which isn't settling with simple analgesia. And this form of management can take as long as 6 to 8 weeks. We usually give them a follow-up appointment after 2 weeks just to make sure that there are no signs of infection, and just to see how they're getting on and to ensure that it's still appropriate to continue with the expectant management. So next we have medical management, which has around an 85% success rate. We use misoprostol. It's actually unlicensed for use for this purpose, but it is supported by the Royal College of Obstetricians and Gynaecologists, and most units are using misoprostol. You should give them analgesia and antiemetics as well. They need proper counselling of what to expect when they're at home. So they will experience pain, they will experience bleeding. They need to know when they need to present to hospital, i.e. again, if there's any signs of infection or if they're bleeding very heavily. So normally you'd say if you're soaking through your pads every half an hour to an hour, then you need to contact the early pregnancy unit or come in and be assessed. Obviously, if there's any signs of decompensation, then they would need to present to A&E. And we advise them to take a urine pregnancy test 3 weeks after medical management is complete, to ensure that they have passed all the pregnancy tissue and that there's not something else going on, such as a molar pregnancy or an ectopic pregnancy. So if they do have a positive pregnancy test, then again, they should contact the early pregnancy unit for further review. Finally, we have surgical management. So there's 2 options here. There's manual vacuum aspiration, which is done under local anaesthetic in an outpatient or clinic setting. Or there's surgical management in theatre under general anaesthetic, which is your D&C procedure essentially. The overall complication rate or significant complication rate in these 2 is around 6%, and 4% need a repeat procedure. So these are things that you have to counsel them about when you're discussing the management options. There's lots more to say about each of these management options, but I think that this is probably all you need to know at your level. And there's similar rates of complications between all 3 management options. So are there any questions about miscarriage or the management that I've explained here? Because we're going to move on to the next case now.
So there's a couple of questions which popped up in the chat. One of them is, when is anti-D needed?
So if they're rhesus negative, and they're having a surgical management or surgical management, then they would need anti-D. If it's a threatened miscarriage with minimal bleeding, then you wouldn't need anti-D. So there's a whole list of criteria which I can't remember off the top of my head, but I can definitely get that information over to you, and then you can post it somewhere.
Sure.
Attached to this presentation, I guess. We can look at that a bit
Sure.
later.
I'll just two other quick questions. Can you explain the difference between incomplete and inevitable miscarriage?
Okay, so let's go back. So yeah, so I can understand that they seem to be quite similar, and they are, but with an inevitable miscarriage, often you see that the fetal heart is present and the gestation sac is seen, but that cervix is open, so that pregnancy is going to pass. Whereas with an incomplete miscarriage, you don't see you wouldn't usually see any you wouldn't see a fetal pole necessarily or fetal heart necessarily. So that's the difference between the two. So with an inevitable, that you often see that there is a fetal heart present and the gestation sac's intact, but that miscarriage is going to happen because the cervix is open.
All right, that's good. Yeah, I think that's pretty much covered the bulk of the questions. There's just one on mifepristone and when that's used as opposed to misoprostol.
So mifepristone, we don't use that for yeah, so mifepristone, that's used more in termination pregnancy. We don't often use mifepristone for medical management of miscarriage. So that's more for your termination of pregnancy, for your not miscarriage.
Sure. So yeah, it sounds like that's for termination, isn't it, as opposed to actual miscarriage itself. Cool. Should we move on?
Exactly. Yes. Yeah. So, okay, the next case, a 36-year-old, gravid 3, para 1+1, presents with vaginal bleeding. Her last period was 7 weeks ago, and similarly to previous, she's got a positive pregnancy test. She's had a 2-day history of generalized abdominal pain, which is now localized to the left iliac fossa. She's had vaginal spotting for 2 weeks now, and she feels dizzy and lightheaded. She's complaining of shoulder tip pain and tells you that she had an ectopic pregnancy, which was managed medically 2 years ago. On examination, she appears to be in significant pain and is lying very still on the examination couch. The abdomen is soft with significant tenderness and rebound in the left iliac fossa. On speculum examination, the cervix is seen. There's minimal dark blood seen in the vagina. And on bimanual, there is cervical excitation present. Her observations are as listed. Her heart rate is 110, blood pressure is 96/62, and rest stats and temperature are all normal. So what is the most likely diagnosis in this case? So we have threatened miscarriage, pelvic inflammatory disease, ectopic pregnancy, incomplete miscarriage, or endometriosis.
So we've got an overwhelming response of C's. An overwhelming ectopic pregnancy.
So there's lots Sorry?
Yeah, so they've all picked ectopic pregnancy pretty much.
Yeah. Good. Yeah, so that's what we should be thinking in this case. I mean, she's got risk factors, which we'll talk about in a second. But yeah, with this history, I wouldn't be thinking of threatened miscarriage. Although again, it could be, but it's not really fitting in with that case scenario that we've got here. PID, again, it could be PID. She could have a tubovarian abscess, so it could be that. But I would be thinking ectopic pregnancy in this case because she's had a previous ectopic as well. And then she has IV access and bloods have been sent, including full blood count, group and save, and beta-HCG. What next? So would you check her progesterone levels? Would you do a pelvic ultrasound scan? A diagnostic laparoscopy? a diagnostic laparotomy or a CT abdomen and pelvis.
So we have a lot of B's coming through, a few D's, a couple of D's, but it seems slightly more in favor of B.
Yeah. So it's B. If we talk about B and D, so a pelvic ultrasound scan. So ultrasound scans are the most sensitive investigation for looking at the gynecological organs. So, so it would be pelvic ultrasound scan. Diagnostic laparotomy these days is very extreme. So we mainly do diagnostic laparoscopies if we did want to go in with a surgical approach, but actually that's no longer the gold standard. So we should be doing a pelvic ultrasound scan on this patient. So ectopic pregnancies, implantation outside of the uterine cavity, 98% occur in the fallopian tubes, of which the ampulla is the most common site. So you can see where a normal pregnancy would implant versus ectopic pregnancies on the illustration you have there. And it's self-explanatory, really. You can see the interstitial, you can see the ampullary, you can see abdominal, you can see cervical. So that's a really nice diagram there. So in terms of epidemiology, the incidence is 11 per 1,000 clinical pregnancies. And if you have an ectopic pregnancy, your risk of future ectopic pregnancy is 10%. So it is quite high. And that's why we advise women to attend for early pregnancy scans in any future pregnancies, so that we could diagnose ectopic sooner in any future pregnancies if that's what was present. Risk factors, we have previous tubal surgery, previous ectopic pregnancy, PIDs, obviously risk factors, so chlamydia, gonorrhea, your STIs, history of infertility, concurrent IUCD use, so that's the coil, whether that's progesterone coil, i.e. the Mirena, or whether that's the copper coil. Use of the progesterone only pill, which I mentioned right at the start of the presentation. Assisted conception, smoking is a risk factor, maternal age over 40 years is also a risk factor, although a majority of women actually have no risk factors at all and they have an ectopic pregnancy. So it's worth thinking about all of these things. If they don't have any of the risk factors, please don't think that they can't have an ectopic pregnancy, because they absolutely can. So investigations, a urine pregnancy test is what you would do initially. Blood test, so you do a full blood count. You do your full blood count because you want to see what the hemoglobin levels are. Are there, is there a low hemoglobin there? Could there be an intra-abdominal bleed that's going on? So your full blood count is really very important. You do a beta HCG as well, because this can inform your management of the ectopic pregnancy if it's stable. And serial HCGs are used mainly for when you have a pregnancy of unknown location. So you do a beta HCG 48 hours after the first one. And if there is a less than 66% rise over that period of time, or a decline in the HCG, then it could be because of ectopic pregnancy. If the HCG is reducing, then it could also be because of a non-viable intrauterine pregnancy. But when you've got those signs and symptoms present in the patient, then you would be thinking about ectopic pregnancy. And as mentioned, it's useful for planning management. We obviously do a group and save as well, in case you need to take this patient to theatre, or in case you need to give her any blood. And in terms of imaging, as mentioned previously, transvaginal ultrasound is the first line diagnostic investigation. It's no longer a diagnostic laparoscopy. So I've just put some numbers in here for you. So sensitivity of a TV scan is 87 to 99%. So your sensitivity is, of the women who do have an ectopic pregnancy, the TV scan pick up 87 to 99% of these. And specificity is 94 to 99%. So of the women who don't have ectopic pregnancies, the scan will confirm that there's not an ectopic pregnancy there in 94 to 99% of those women. So again, laparoscopy is no longer the gold standard for diagnosis. False negative laparoscopies, there is a risk of that of around 3 to 4.5%. Particularly if you perform these too early in the development of the ongoing ectopic. So you'll go in and you won't see anything, and then you'll think, okay, there's no ectopic pregnancy there. And then they'll present 2 weeks later with a ruptured ectopic pregnancy, and it's just because it was too early to see when you did that laparoscopy. So the scan is much more sensitive. So what you might see on scan is a cystic adnexal mass. That's the most common finding in 50 to 60%. You may see an empty extrauterine gestation sac in 20 to 40% of women, or you might see an extrauterine gestation sac containing a yolk sac and/or embryonic pole with or without cardiac activity, but that's actually only in 15 to 20%. If you do see a small amount of free fluid in the pouch of Douglas, then it doesn't necessarily mean that there is an ectopic pregnancy, because you can also see that in an intrauterine pregnancy as well. So in terms of management, you can offer conservative management for ectopic pregnancy. But you have to meet very strict criteria to be eligible for this approach. So they must be clinically stable and pain-free. And the tubal ectopic pregnancy must measure less than 35 millimeters with no visible heartbeat on transvaginal scan. So you can't offer this for a live ectopic pregnancy. And the beta HCG level should be less than 1,000. They have to be able to return for follow-up, because this does require very close follow-up of the patient. They need to be coming into hospital regularly for bloods and for review. You can also consider it as an option for women who meet that criteria that we've just mentioned, except their HCG can be up to less than 1,500 as opposed to just less than 1,000. So these are the women that you need to counsel really well. And again, it's something you can consider. It doesn't mean that you can definitely offer it. It just depends on all their other symptoms and how compliant you think they're going to be with returning for follow-up. So you should do repeat HCG levels, and that's serum HCG levels, on days 2, 4, and 7, and then weekly until you have a negative result. And a negative result is less than 20 beta HCG. If the HCGs don't fall by 15% between each of those days, or they stay the same or rise from the previous value, then you need to reassess the woman's clinical condition and reassess the management that you're using. So you may need to think about an alternative form of management if that's the case. So medical management, we use methotrexate, which is cytotoxic, and it's actually unlicensed for use in ectopic pregnancy. But again, it is accepted by the Royal College, and we're basically using this in, I think, all units now. Women who can be offered this management must not have significant pain, and they must have an unruptured tubal pregnancy measuring less than 35 millimeters, again with no visible heartbeat on transvaginal scan. And the serum HCG should be less than 1,500. They should not have an intrauterine pregnancy as confirmed by ultrasound scan, because women can have heterotopic pregnancies, which is a pregnancy in the womb, as well as an ectopic pregnancy. So they mustn't have an intrauterine pregnancy if you're going to use medical management. And they have to be able to return for follow-up. And they also need to be counselled that they have to wait, well, they should wait at least 3 months before future pregnancy, because of methotrexate being cytotoxic and teratogenic. So now we'll move on to surgical management. So there's salpingectomy and salpingostomy. So salpingectomy is removal of the tube along with the ectopic pregnancy in it. And a salpingostomy is opening up that portion of tube, removing the ectopic pregnancy and resuturing that tube, or leaving it to heal depending on how big the ectopic pregnancy was. So that's a lovely picture there of an ectopic pregnancy. Can you all identify where the ectopic pregnancy is in that? I'll just give you a minute just to have a look at that.
Okay, so people are saying on the left.
Yeah, exactly. So here, so the head of the patient is up at this end, and the legs are down on that end, and you're looking down at the pelvis. So this is the uterus here. This is a healthy fallopian tube, or relatively healthy. You can't quite see the end of it. And on this side, this is this fallopian tube, and there is a big ectopic pregnancy there. You can see it's bluish in colour. It's just clearly an ectopic pregnancy here. And there is some blood in the cavity as well. It looks like she's got some adhesions. So you do a 360-degree view when you do a laparoscopy, and you look for perihepatic lesions as well to see if there's any PID. So surgical management, you should offer it as a first-line treatment to women who are unable to return for follow-up after methotrexate treatment, or who have any of the following. So significant pain, an adnexal mass greater than or equal to 35 millimeters. If there's a live ectopic pregnancy, i.e. a fetal heartbeat is seen on scan, and if their serum HCG levels are greater than or equal to 5,000, then again, this is the best option for management. Now, whether you do a salpingectomy or salpingostomy depends on what you find when you go into the cavity, and this is what you should counsel patients about. That's what we counsel patients about. So we explain that when we go in and have a look at the pelvic cavity, if the other fallopian tube looks healthy, then we will remove the whole tube along with the ectopic pregnancy, so the affected tube with the ectopic pregnancy. However, if the contralateral tube looks unhealthy, or it's stuck down, or we think that there could be fertility issues if we remove this tube, then we would perform a salpingostomy. But if there are no if there's no underlying fertility issues, then regardless of which management option you choose for these women, whether that's conservative, medical, or surgical with a salpingectomy, then their fertility rates are the same after whichever management option they have, as long as they don't have any pre-existing fertility issues. And I think that's really important for patients to know, because I guess they would just think that if you're removing my tube, then you're reducing my fertility drastically, which you're not. It doesn't go down by 50%. There's still good fertility prospects as long as the contralateral tube looks healthy. And then there's this sort of middle ground where you can either use methotrexate or surgery. So that's if the serum HCG is between 1,500 to 5,000, if there's no significant pain, if there's an unruptured ectopic pregnancy, and if the adnexal mass is less than 35 millimeters with no visible heartbeat, and there's no intrauterine pregnancy. So you could use either methotrexate or the surgical management in these cases. And there's a nice flow chart here for you just to take a read of. Okay, we're at the end. And these are my references. So this guideline here, ectopic pregnancy and miscarriage diagnosis and initial management, is the NICE guideline. It's a good one to take a look at. I don't know whether you would have access to the RCOG e-learning, but you can take a look because some of these are actually open at the moment, so you could probably go onto the RCOG website and try and access them. But the early pregnancy loss management is a very good one to have a look at as well. And there's also a green top guideline by the Royal College of Obstetricians and Gynecologists, which is diagnosis and management of ectopic pregnancy. So take a look at those.